So to kick off our first session, the interconnections and well-being of mental health and sexual health, I'm honored to invite Dr. Krystal and Odile Thiang to the panel discussion to share their expertise on improving the quality of life of PLHIV from the meso and macro perspective. So, Dr. Krystal and Odile? So, Dr. Lee is a specialist psychiatrist and a fellow in community medicine. Prior to her psychiatric training, she focuses on HIV prevention and surveillance in the Department of Health. And on community basis, HIV epidemiology studies in the Chinese University of Hong Kong. Currently, she is the member of the Medical Advisory Panel for AIDS Concern, and she's providing consultations in the Queen Mary Hospital and the Integrated Treatment Center. Dr. Lee published an article last year looking into the intersections between mental health, substance use, and sexuality. And the study focuses on the recovery process of HIV-infected MSM with history of chemsex. And Odile is a very experienced pediatric nurse practitioner with over a decade of hands-on experience in Toronto and Hong Kong. Odile is a teaching fellow at the Hong Kong Polytechnic University and an honorary nurse consultant at the Hong Kong Children's Hospital. She has robust experience in clinical care, quality improvement initiatives in healthcare, and mental health stigma reduction education. Her commitment to serving marginalized communities lead her to work with survivors of sexual violence and domestic violence and vulnerable LGBTQ+ youth. As the lead clinical advisor on anti-stigma and training at Mind Hong Kong, Odile actively advocates for affirming and safe mental health care for LGBTQ+ communities. Introduce myself again, I'm Amy. I'm the assistant manager for the PLHIV support team. And from my work experience, I've encountered people living with HIV of diverse backgrounds, age, and gender identity and sexuality, from newly diagnosed to people living with HIV for decades. The psychological distress is common among newly diagnosed and people living with HIV for over a period of time. They have an increased risk of mental health conditions, so I'm honored to be able to learn from two experts in the mental health field. So I think I would like to ask Dr. Lee first. What is your experience in working with PLHIV? What is their journey look like in the medical system and community? And are there any common challenges they are facing?
Thank you, Amy, and thank you, AIDS Concern, for the very kind invitation. So what's my experience with working with PLHIV? I need to put up some slides to guide myself talking. So I've been in the field for many, many years. My first experience was with PLHIV, was with patients with hemophilia. I'm not sure if any of you have come across patients with hemophilia and HIV in your practice. It's been, I was counting, 40 years since they contracted HIV in Hong Kong. And at that time, 20 years later, when I first joined the SPP, I met most of them, I think 20-something, if I remember correctly. As a very junior medical doctor, I was talking to them and they told me all the stories, all the discrimination, all the mental problems, all the physical disabilities they have been facing. And I was very touched by each of their story. I think that what they have gone through is very unique. It's like an iatrogenic infection. And at that time, it was a fatal illness. It was a fatal disease. Everyone was like very hopeless and they were struggling with life, their families, their work. So that was my very first impression of HIV infection. I mean, people with HIV. I don't know if any of them are still here today. It's been 20 years, it's been 40 years. I still remember most of them, their stories, and I was very touched by them. And I was very struck at that time. And that was what Dr. Ho was mentioning, the ex gratia payment they have been receiving. And we actually, from that study, we increased like more financial support to them, and we coordinated all the medical services they have to go through, from orthopedics, medical, and then liver problem, hepatitis C, and then HIV. So many problems, and then we try to delink the problems they get through services and to smoothen the coordinated care they were experiencing. So that was my very first impression of mental health, HIV. They were full of anger. They were so pessimistic about their future at that time. And then the second experience of PLHIV I had was the the MSM, the epidemic that started 20 years ago. So again, I interviewed some of the patients, how they acquired HIV through parties. At that time, ecstasy, ecstasy. Just thought it was a party thing, happy, recreational. And then they didn't think about having HIV at that time. And then 20 years later, of course, is the chemsex Dr. Ho has mentioned. The patients that I've been seeing are suffering from meth addiction, meth dependence, depression, psychotic disorder. And many of them thought they should be quitting, but it's so difficult. And they have gone through like different stages in abstaining, relapsing, abstaining again. And of course, struggling with whether I need to tell who is supportive, who may not like me at all. And then just 2 words about the last one is the female sex worker. Again, Dr. Ho mentioned, so I mentioned it again. I was working with another NGO, and then we detected some HIV infection in female sex worker locally 2 years ago during the COVID. I just want to mention one point is that after we told them, oh, this is HIV, and then we took blood, it's confirmed, they disappeared from the NGO. We refer them to the clinical service. They were there, but then we became disconnected from the community. Perhaps that highlighted the stigma, the self-stigma. They don't want to be known to others, get in touch with others. I don't want to talk about HIV because the NGO, one or two staff would know about their status, and they get disconnected. So perhaps that's one story that reflects the self-stigmatization that I saw from the female sex worker infections just 2 years ago in Hong Kong.
Yeah, that's very true. I think from our experience, we have trouble maintaining contact with newly diagnosed positive case from outreach, like mobile testing. Oftentimes, they gave us a fake number, and then we wouldn't be able to contact them. Or after a few contacts, they blocked us. And then actually, sometime maybe half a year later, we received a text from the phone, and then they came back asking I got some symptoms, and how do I access healthcare and stuff like that. So that does reflect the self-stigma or the self-isolation and mental health condition, when they newly diagnosed. Yeah. So I think, Odile, you have more experience working with LGBTQ plus folks. So I want to hear your insight on, is there any challenges they face that is a barrier to their sexual well-being?
Yeah, so I'll segue from your talk about stigma and continue it. Stigma is everything. When we're talking about health in general and sexual health. I think oftentimes we don't associate stigma, we just think about it as this is just a health problem, but stigma is everything. Stigma is going to impact, from a macro level, it's going to impact policies, it's going to impact financial distribution. We were talking about that earlier this morning. And on an individual level, it impacts how a person actually gets to explore their sexual health. So individuals within the LGBTQ community don't actually get to naturally explore their sexual health and sexual preferences in a healthy way, meaning that throughout high school, they generally have to stay closeted, either because of bullying, they have to stay closeted from their family members, so they don't have these conversations at home either. And so what happens is when we have to go into the shadows, that's when issues arise, right? You might be engaging in chemical sex, like we talked about this morning and just now, which is a much more risky behavior. Because you don't have like the interactions that other cisgendered hetero youth will have in high school. You don't get to like go to a guy or a girl and say like I kind of like you, start dating, doing like those natural progressions, right? It has to go underground. The other issue as well is we are not really good here in Hong Kong at sex education to start with. And so even if they do get some information on sex education, they get it from a hetero perspective. And so individuals who are not engaging in hetero sex don't actually understand what are their risks and what do they need to do to keep themselves safe, because we're talking from a very, very specific lens, which does not speak to them. I'm just going to go back really quickly to the chemsex. A lot of the issues with chemsex is the community that is engaged in chemsex, they're engaging in it because of kind of underlying anxieties, underlying stigma and self-stigma, using substances to either ease anxieties around these interactions because they don't get to have them in like a normal setting on a day-to-day basis. And so that's sort of, it comes back to the stigma, the self-stigma, the homophobia, internalized homophobia, and other kind of communication that they're getting from their environment. So I think it really, it's everything. And one of the reasons that got me on sort of my allyship journey was it was in my first 2 weeks of becoming a sexual assault nurse examiner, and I was called in at midnight. I got a page, and the dispatcher said, you need to come in. There is a young man here wanting to talk about a sexual assault. And I thought, oh my God, it's a guy. Most of my patients during my month-long training were all women. I had lots of patients, but they were all women. We did have lots of training about LGBTQ concerns, so I had to kind of dig deep and kind of think about, okay, what do I need to do if it's a guy? Okay, it's the same thing, but what have you. And when I got there, we started chatting. We talked about his interaction. And what happened to this young man is something that I've heard over and over again. I've heard it from my own friends. He, got this date online, went to a neighborhood that he's unfamiliar with because, God forbid, should he be seen in his own neighborhood with another person, another guy. The person that he met there was not who he represented online, and then he was assaulted, right? So when you're not able to explore your sexuality in a healthy and natural way, you have to kind of do it in the dark, do it in the shadows. We were able to connect because I had to talk to him kind of as a girl about, safety and dating. But when you're in the shadows, you don't get to have those conversations with your friends. I had those conversations with my girlfriends, like, what do you do when you go on a date? What are precautions that you take? You make sure you have extra cash so that you can get out of there. Or a girlfriend would tell me, do not meet this guy, it sounds really sketchy. But they don't get to do that. And so we have to be really cognizant of really working on the community, really working on the population at large and reducing the stigma, both of mental health and of sexually transmitted infections and LGBTQ identities.
Yeah, I think the lack of inclusion, diversity of no matter gender or sexuality, and also maybe like neurodivergent like inclusiveness is causing people to not be able to say what they are experiencing. They kept closeted, and like the risk of turning to substance use would be high, and like having other mental health condition would be high. Yeah, so we talked quite a bit about interpersonal and self-stigma. Dr. Lee, I wonder, like, if PLHIV or LGBTQ plus folks are facing some structural stigma coming from cultural, social, and legal factor, and on a macro level, how can we improve the quality of life of PLHIV folks?
Very difficult questions. Anyway, so I was thinking all the self-stigma, discrimination, closeted. So whether you're just being not the majority in the group because you are like having different like non-heterosexual, or having an HIV infection, so that actually put on much more extra stress on your psychological demand. So I just listed out some of the issues that I thought of for PLHIV, for example. So the issue of discrimination, and I remember Amy also like told me, PLHIV would have problems getting into elderly home. Say, the elderly home may like check their medical history, and then infection. I don't know. Maybe Amy can share a little bit more. But then they just go through all the like social services, medical services. They always have to decide whether I should like reveal my HIV or whether I should like conceal. So that put an extra stress to it, because like this with you every 24 hours every day for every day in a year, you have to think about whether you should tell people or you should conceal. I think that's a lot of stress for anyone. And apart from like overt discrimination, I think bad attitudes, it's one of a very important sort of stress as well. So think about, for me, like死肥妹即係鳥醜樣 okay? So all these kind of bad attitudes, 你咁肥行開啲 okay? I mean, if that refers to your sexuality or HIV, say, I think that would be really sad, especially if I were really young and I'm not resilient enough and I'm not having good support from my friends. That would be like really stressful. Other worries about future, right? I'm alone, I don't have a partner, I'm HIV, I'm not lovable. Like, no one would love me. I worry about transmitting to others. So worries about future. I mean, I also worry about my future. I mean that having HIV or being not a majority of the population, I think that would really create extra worries for them. And from my experiences working with PLHIV, I think some of them would have a lot of stigmas and different meanings attached with HIV, the virus. Many of them would have shame, like feel shame and guilty. And the core value we talk about is that I'm not lovable, no one will love me. I think that if having that concept for the rest of your life is so distressing and it's so dark. So I think all these would create lots of demands psychologically for PLHIV. And if you are not being resourceful enough, you're not resilient, you don't have a good supporting network, you don't accept yourself having the virus, you don't accept yourself being gay. And you know how to solve them. You don't know how to solve, I don't have like place to live. I don't seek Amy's advice. I don't go out to ask a district counselor for help. So that would be like really stressful, having a stressful situation that may really hamper their quality of life and mental health. But of course, there are situations or there are individuals who are really resilient, having good problem solving, self-acceptance. They may turn that around and they would like internalize that, it's okay, I understand why people are doing this. I still have many good qualities, I still have many good friends, and they can move on. So I think that's the issues that they were facing, and if they are not being resourceful, that would create lots of mental health stress for them. I should go on, yeah. So what can be done to improve the quality? So I searched like AI, and then I was thinking how to change the social environment, being more supportive and less discriminating. So I think that's a very good model for me to talk about how we make change, improve acceptance. So that's the social change model that talks about individuals, group values, and societal values. So if each of us can embrace the compassion and then find some groups to collaborate with common purpose, and through that interaction, we can perhaps bring about change in the society for the common good. So, of course, everyone in different positions in the society, I think they have different methods to work with the people around them. Maybe in your school network, your friends, your office, in your reaching out to other groups. So all these would make changes in the society. I was searching that what's actually acceptance, what should we do? It was back in, again, many old days. I mean, old days, 23 years ago, we already set a paper by the ACA at that time that what's actually promoting acceptance. They have listed out all the principles, things should be done, but two of the principles are listed here is that non-discrimination is not limited to anti-discrimination, but also with positive qualities of equality that we talked about this morning, compassion and mutual respect, and acceptance of whatever people entails a change of attitude, cultural norms and values. So I think that would be that can guide we go forward. What should we be going through? And Dr. Ho mentioned the ACA. Of course, this is one important chapter in the strategic area that we should work on the policy, we should build our capacity, we hopefully can change some guidelines, regulations, we go on to have media campaign. These are some of the things that we can work through in a more macro perspective. Yeah, so that's how I think being individual or affecting your groups and we can make a change in a society.
Yes, that's very true. To promote inclusion, diversity, and doing anti-stigma education is very important. And I believe our small efforts as an individual in the system, and then slowly we can build bigger changes and a better environment for people of different diversity. So we have mentioned quite a bit of concept of intersectional. Sorry, I'm tricking up on this word. Yeah, intersectionality. Yeah, that's a very tricky word. Yeah. So in the context of PLHIV and LGBTQ plus folks, it basically means there is a complex cumulative way in which the effect of multiple forms of discrimination and oppression would overlap and intersect to create unique dynamics and inequalities. For example, an elderly gay person living with HIV, living in an elderly care home, with their adult child all away overseas, never knowing his own status. Or a 30-year-old woman newly arrived in Hong Kong, needing to disclose her HIV status to her husband because they're planning to have a child. It's multiple factor, multiple identity, all overlapping and really complex situation. And everyone is experiencing their unique experience and oppression. Yeah, so my question for Odile is, in response to the intersectionality, I got that right, how could we respond on an organizational level?
So I think the most important thing is to remember and understand that no community is a monolith. and the LGBTQ community is not a monolith. Even within the alphabet salad of LGBTQ, you have almost like hierarchies of privilege and hierarchies of marginalization. So, for instance, we have gay men who, just by the virtue of being men, have a certain amount of privilege, and that kind of translates into the general, like how the general population kind of sees them. On the other end of the spectrum, we have transgendered women, and particularly if these transgendered women are associated with an ethnic minority. And so you have kind of layers and layers and layers of both marginalization as well as privilege in certain cases. So understanding that is really important, which also means that it's really important for us, if we're talking from an individual level, to, one, do a really good psychosocial assessment of that person to understand what are the stressors that are impacting their day-to-day lives, and not just assuming what they are. From a more structural perspective, I think it's really important for us to never, ever, ever embark on doing anything towards a community without having the community say, fully embedded in it. So nothing about them without them. I have seen quite often very well-meaning people in privileged positions that are not within the community who want to be allies and who want to support, embark on kind of, strategy or kind of projects, but never actually asking for the needs of the community. And when we're asking for the needs of the community, we have to make sure that we're not just asking like the gay guy that's like around, but we're asking like a wide variety of individuals so that you're getting those layered responses and layered feedbacks about the services that you're about to provide, or the changes that you're trying to make. The other thing that is really important is to always have a trauma-informed approach when we are, either dealing with an individual on an individual level or on a more structural level. And a trauma-informed approach just means that we are understanding that there are, because of all these intersectionalities and because of all these layers of either of marginalization, people are coming in with their own sets of either small t or big T trauma associated with their different multiple identities. So, just keeping that in mind and not just painting everybody with like one broad brush stroke and making assumptions. So really important, getting the perspectives of the people that we're trying to support.
Yeah, getting the consumer perspective, never assuming, and like creating a safe and inclusive environment for the people to be themselves, like in like a safe space and in the community. Yeah, so it was a great discussion. Too bad we have a limited time. So I think just to wrap up, is there any take-home message for the audience?
Already prepared. So, and it's a summary of what we have talked about already, right? HIV is not a priority health topic. Dr. Ho mentioned that. I think that's a very important part, that how we can strike among different competing challenges. And specifically for HIV, or like sexual mind, or I think more for HIV, that patients are highly invisible. I think that's a very important part of the issue. I mean, for SMA, people can go to 最激係嘛？7點咩話？東張西望 yes, you can go to 東張西望 and then talk about, oh, it's a very sad story, we don't have money, and then people will donate. And remember in the past, the newspaper that have already been like disappeared, they also have some donation, 送亂, and people can make their stories out and then ask for compassion from people in the media publicly. But for HIV, I think that's like a different story. It's very difficult for them to talk about their difficulties public. I hope we can, like, if I talk about that thing, if we have some people who can like cope with that it's okay, it's infection, be a very strong, resilient, self-acceptance, patients can come out and talk about their difficulties for the community, and that would help us compete for these resources with compassion, because we thought people should have compassion, right? And each of us, before we do that, perhaps we can all be the agent for change in various groups, as I've mentioned, maybe in your social network, your office, your nurses, your staff. I think from what you practice and believe, you can cultivate and influence change in the people around you. And embrace compassion and mutual respect as really the most fundamental value of your professionalism and the wider society as well. And then with that, I hope we can make some change in the community.
So I'm going to give my kind of final thoughts from a cisgendered hetero woman perspective. What I have seen from working with the LGBTQ+ community is an immense level of resilience. Not weakness, not, there's struggle, but an immense amount of resilience. So from my perspective, they don't need allies to do anything for them. They need us to walk alongside them and help with our privileged position to elevate their voices and allow them to speak for themselves.
So thank you, Dr. Lee and Odile. So I think we'll wrap up this session, and we'll join Dr. Gordon Wong after together for a Q&A session. Yep.